So, as you probably all know, I'm Rob Martin, Assistant Dean for Continuing Medical Education. My co-presenter, Jack, is Assistant Dean for Faculty and Curriculum Development here at Winthrop. Welcome, Jenny. Thanks for coming. You haven't missed much. So we have nothing to disclose in the spirit of CME, no financial relationships. And so today's learning objectives, at the conclusion of today, we hope you'll be able to describe the factors that distinguish adult learning from childhood or early development learning, compare the efficacy of various learning activity formats for achieving changes in knowledge and attitudes, competency, and performance, those four all under the umbrella of practice change for clinicians. Interpret learning preferences from personality types, professional customs, and practice settings of your target audience, especially interprofessionals. And this is less of a science than an art, but there are definitely correlations that can produce particular kinds of results. And then lastly, we'd like to touch on how to begin to identify barriers and even anticipate barriers that could prevent learning in continuing ed from being actually applied in the practice setting. So those are the four learning objectives for today. And I will be sending you guys a PDF of the slides after class, so it may go more quickly than you can actually jot all this stuff down. You'll have that PDF afterwards. So today we'd like to start with just a 5-minute review of last week. For those of you who were not at last week's session, we'll connect up to some of that material. We'll go over what actually is the difference between adult learning andragogy and child learning pedagogy. And then we'll look at some of the differences that makes healthcare continuing education, continuing professional development, different from other professions, for example, law or accounting, or other professions that have a continuing education requirement. We'll go over some of the activity formats that are commonly used in CME and CE and CPD. It's a bit of an alphabet soup, but we are converging toward a more interprofessional designation. So I would say CE is the most inclusive, but we don't want people to lose focus of their profession. So we use all the terminology to keep everybody oriented. We'll go over learning preferences, personalities, norms, settings, and contexts that can influence preferences, and then the barriers. And then, do we want to change the color scheme to improve performance? Gee.
Should we get audience response and vote?
Yeah, please use your clicker. Gee, I'm just going to fly blind here. And so all of that didactic about 25 to 30 minutes, and then we'll have a half an hour hands-on development session where if you've brought a concept for continuing ed in your profession or for your department, we'll be able to actually do a worksheet session, and Jack will walk you through sort of a flowchart process, which is really, I think, very useful. So last week on Game of CME, CE, we went over the learning objectives. Last week were to discuss what Bloom theorized as 6 levels of observable action in learning, from knowledge at the very foundation up through real comprehension, application of learning, analysis, synthesizing new products or new theories, and then evaluating the experience. So that's sort of Bloom's foundational pyramid from the 1950s. From that grew out of that Bloom's taxonomy of measurable verbs. So when you're writing a learning objective, you can't just sort of throw in any old language. You want to focus in on your sort of first verb being something that can be measured, because as it turns out, outcomes is a science that we have gathered a lot of data around. And why does measurability matter? Because we all work with very scarce resources: money, time, space, and very importantly, sometimes hidden, is learners' goodwill. If you waste a learner's time on their first exposure to a learning curriculum, they may not come back, or they may be resistant the next time you have them in the room. Well, goodness.
The last one.
I'm sure we'll have another visit from that little pop-up. We looked at last week as well some bad examples or poor examples of learning objectives that were not measurable and how to tune them up to improve measurability. And then we made an early attempt to relate the measurability to a framework known as Miller's framework, and his successor or gentleman who expounded on his work, Moore, who really mapped some of the learning actions and practice changes to specific outcomes in the practice, including translation into patient case differences, patient health, and aggregate population health. So there's a sort of a history of these frameworks evolving into more detail, but Moore's outcomes are very much used in educational grants. They will often ask you what level of Moore's can you measure, and then they will hold you to returning data on that level. If you say we will measure changes in patient health, they're going to want a wrap-up report 3 months after the grant on exactly what patient health data you were able to measure. So Moore's levels, just because this is so important in resourcing, it starts out with the first level, your sign-in sheet when you came in today. That's level 1. Did people show up and the data is in the sign-in sheet? Were there fannies in the seats? And level 2 would be, how did the learners feel? If we give you a survey, did you feel the learning was applicable to you, or did it light a light bulb for you? So that's the satisfaction level, level 2. Then level 3, you get into actual knowledge that is maybe more scientifically measurable. So knowing something, the declarative portion of level 3 might be something in a test, a post-test, a pre-test. Knowing how would be demonstration, procedural knowledge. Level 4 is competence. Can you reproduce what we've shown you in the learning to get a result, according to a level of success that we can measure? Performance is, did you take it back to the clinical setting and use it? Did you go back after class and really change how you practice based on something you learned in continuing ed? So that's knows how, shows how, and does, or the Miller framework. And Moore added the patient health and the community health outcomes levels to that, really to plug into the triple aim and the healthcare mission. So we also talked about, aligning learning objectives to the instructional strategies, which would be the methods you design. We'll focus on those today. And later on down the series, assessments. And the reason that you want to really align these 3 elements is because if you're not aligned, you'll see kind of odd, dissonant results. Students might feel that a test had nothing to do with what was presented in class. Instructors might feel that students lacked true mastery, even though they're testing adequately. So those are symptoms that objectives, methods, and assessments are not really aligned. And lastly, we don't ever want to sort of pull a bait and switch on learners. There is sort of an implied contract when you present learning objectives. You really need to deliver on them, and not have sort of surprises and gaps between what was promised and what was learned. So let's move into the principles of adult education. Let's just talk, first of all, does anyone have any instinctive differences here that they could point out? What's the difference between teaching adults versus children? Goals? Can you say more about that?
Would have more of a goal of learning, like whether it be getting an advanced degree or whether it would be learning a particular procedure, whereas children are just kind of sucking in, or seems to be sucking in more of anything
Sure.
that they can absorb.
Yeah. Practical and purposeful versus sort of filling a container. Anyone else?
One's like more active, like one's more, as were children more passive. They just kind of,
Yes, absolutely. Adults have more of a sense of control over participating in the learning process and maybe even customizing and individualizing what they want to learn rather than sort of, puppeting back material, although, children can certainly have the experience where they're opting into aspects of that as well. But in generally, those are both very good observations. So the focus for adults is generally independent, self-directed, and often cooperative among other learners in the group. Some cases, for example, learning online by yourself, maybe not so cooperative, but there are ways that can be a discussion board, can be cooperative, and things that make it more of a group setting. With children, importantly, the student's experience is completely mediated by the teacher and the teacher's, slow revealing of what they know. And if they don't know it, the students may not have a chance to uncover it. They have less of a context to where the learning plugs in, so they may not be able to explore the outer margins of the knowledge being presented. Getting back to Dr. Lee's point, the control and authority piece, the teacher really does control what the children experience. Adults often can sort of break off onto their own path through a pair and share, a group exercise, role play, and can direct part of the learning through purposeful questioning. As Jenny mentioned, Dr. Castillo, the scope for adults is often very practical. It's problem-centered, not so much subject-centered with children. You're trying to teach children maybe the broad canvas, whereas the adult may have a problem in their back pocket that they're coming in with needing to be solved. And then adults generally want to use the learning very immediately or very soon. There's a sense that children are being taught something, taught a skill in order to save it up for later in life. Things like polynomials in math. They're probably not going to be using those in a real world context right away, but certainly storing that knowledge away for future use and hopefully retaining it. And then with adults, there's the sense of interacting and critiquing the learning, giving an opinion, giving feedback about what the learning is, whereas children, it's much more foundational, giving them tools to build other learning. Adults, may really have some say in pushing back on the material. So that's an important difference. And then grades, the extrinsic motivation of grades may be less important for adults compared to the problem-centeredness and the applicability of the learning.
I have a question. Why wouldn't it be the other way around? Because for example, and again, I'm not a physician, so I don't pretend to be. What about learning a procedure? Wouldn't that be considered important, or how do you define important in this, in terms of that aspect?
Okay, so a procedure, yes, if the procedure is graded, like an OSCE, yes, may be less, is important in that sense. In a sense like today, you're not going to be graded, so you're here for a different reason, for something more intrinsic. Whereas a young person often is very focused on those grades and those extrinsic rewards. But I agree with you, it's not always a clear distinction. And there are a couple links to further reading here if you want to go into this original theorist, Malcolm Knowles, I think in the 60s, began to look at these differences. Back when the childhood education system was very different from what a lot of us went through. So some of this framework may be not as current.
Introductions.
Oh yeah, we forgot to do that. Yeah, sorry.
Well, a couple of you were particular. wasn't here last time. And one of the things that we did was writing learning objectives and some of the rubrics that we used to measure outcomes. And there's simply a worksheet that we have. So one of the things about adult learning principles, there are a number of them, of course, Malcolm Knowles in particular. And some of you, Jenny, knows Dr. Lee as well, my interest in self-determination theory, based on three things. Being an autonomous learner. So you probably had more joy learning things that you wanted to learn, right? Okay, so what that might be. It could be a hobby, it could be painting, it could be fine wine tasting or something that you enjoy. You don't get a grade for it. You do it because you really enjoy it. There's many things that you might do for that. But also to be competent too. So certainly in medicine, competence. What you know and what you can do. What you know and what you can do, right? So like we're having these ACLS courses now going on for the residents. So being able to know how to resuscitate, but then how to do it too. It's performance. And the third one is cooperation, collaboration, learning with one another. Those are kind of the three elements that adults really do more of, and being more autonomous too. Obviously, we have standards that we have to abide by, but still, I think those are the three kind of elements of my. Somebody,
just for the sense of group cooperative learning, I think we should introduce ourselves to each other. I'm Rob Martin, Dr. Castillo.
I'm Jenny Castillo.
Dave DeSimone.
Elisa Berkeley. Linda Marshall.
Joe Ringhill.
Peter Sandry.
Diana Richmond.
Robert Lee.
Jackson.
So as we've mentioned in the past, we have many different professions represented here, and that's great because it provides contrasting perspectives on what each of you may have wanted to get out of the learning, as well as what type of learning you're planning to plan and design using today's material. So how does healthcare, continuing professional development, or continuing education differ from other professions, non-health, non-clinical professions? Does anyone have any instinct or knee-jerk reaction to this? Research? Okay. Evidence-based. Regulated, absolutely. Mandated, sure. So, one thing that I see in healthcare and that our learning is continuous, partly because of changes in technology, changes in therapies, changes in approaches. Certain other professions may be more episodic in their continuing ed, not all the time. That's one possible difference. The variety and diversity of knowledge that you can choose to keep up with in healthcare is vast. The more we specialize and subspecialize various areas of medicine, it's like drinking from a fire hose. Not many other professions have that latitude and vastness of subject matter. Specialization and complexity, again, this gets to Peter's point that you may have to demonstrate a very complicated sequence in a procedure. So there are unique challenges in testing the competence and knowledge, just because the complexity is such a factor. Often, increasingly in healthcare, because of our complex systems based in our workplace, the learning has to take place in the workplace. I think less prevalent are going off to conference centers or big hotels to get continuing education. And when you get that kind of education, it's very different from what you might be learning in, for example, a simulation center, or even some of the very specialized conferences we do here, live conferences, grand rounds, workplace-based and system-based learning. It's increasingly more interprofessional. You I rarely see continuing education that is composed of only one profession. We have, providers at different levels and teams composed of people who trained in very different modalities working together on cases. So the education needs to be interprofessional as well. And in terms of the regulation and the authority, there are organizations promulgating standards and guidelines, specialty boards, but also the government. We are possibly one of the most regulated profession in terms of the education of any profession in the U.S. And then, of course, the outcomes, the higher stakes, quality of life and sometimes life itself can be on the line based on the quality of your continuing education. So I think there's maybe less forgiveness for not really getting competent in healthcare compared to certain other professions, accounting or law or things like that. And so our big regulator, the Accreditation Council for Continuing Medical Education, that regulates medical continuing ed, is very open-minded about formats. They don't proscribe or prescribe any particular format as long as it's based on learner need, a needs assessment, and that needs assessment was conducted in some objective and evidence-based way. There's a link if you guys want to read up on the criteria for accreditation, but this is a competency we have to continuously document for Winthrop to show that, we are taking this on, matching formats to objectives and desired results. So what are some of the formats? Well, right off the top, I know there are live formats and there are things on the web. So, but we have increasingly more choices. Back in the day, there used to be only really those two formats. There was a live conference, which was generally a whole day, or, Grand Rounds being also a member of the live category. And then there was what were known as enduring and started out as just sort of published articles with a post-test in a journal. Now those have migrated to the web and maybe a video and a test. The difference being those are self-paced. That element of control in a live, you have less control and less autonomy in a live activity because the agenda is somewhat fixed. But now those types break into subtypes. For example, in a live, there can be a purely didactic lecture type of session. Better are sessions that involve discussion and feedback. And even better, allow the learner to try out the learning. So those can be mixed. You can build an agenda that has components of all three. And you can have lectures, you can have videos, you can even have simulations. I think a particularly brilliant example that comes to mind of a simulated case demo, if any of you went to see Sim Wars last fall, I believe it was, it was two teams that simulated an ED case, admission for a drug overdose, and the audience was on the edge of their seats. There was a judging between the cases, and the audience, sort of gave feedback. That was one of the most creative and involving of the learners without having the learners actually contribute to what went on. They were merely passive participants in a theater-like setting, but it was really well done. And so, there are ways that you can turn that sort of less participatory into a very engaging format. Discussion-based, many of you have, do these every day. There's Q&A sessions, roundtable sessions, think, pair, share, flipped classroom, which we hope today is an example of. And hands-on, Dr. Castillo can tell you they work very hard at simulation lab, creating fidelity in the lab to the clinical scenarios. And so that's a way to really translate the competence aspects. And precepting is another way, shadowing another clinician and in a more live clinical setting. Now, I do want to point out, enduring, those have differentiated themselves. Performance improvement, quality improvement activities, web-based activities. The print-based tests still exist. They're less popular because they take sort of a lot of labor to score those tests and transmit the tests through fax or the mail. The print-based video and monograph, yet another example. So, team-based learning is a theme we really want to cover. Anytime you have the interprofessionals, that's known as TBL, team-based learning. Another piece of vocabulary you should have is computer-based learning. Again, many formats can share that. And then practice-based learning, precepting, simulation, PI, really involve use of the practice tools on site and not in the abstract. And flipped classroom is a favorite of Jack's and mine, because it pairs the best of both modalities. So it's the idea that part of your learning is self-paced. You get a pre-course activity, you work on it, and then you come to the classroom not so much for didactic lecture, but for coaching and practice sessions and workshopping of those ideas. So again, it's a bit of a buffet of different dishes, but I encourage you to think of, when you're planning your activities, sample some of these formats. What would happen if we added a think, pair, share to this activity that I'm planning? What would happen if we added a case simulation? It doesn't have to be just the traditional tools. So now we come to our first sort of polling session, and I think you all probably have keypads in front of you. Just in general, thinking back over your career and the learning you've had, do you prefer more of the live, scheduled learning, or are you someone who prefers the self-paced learning? Or do you have no preference?
You ever used audience response before? It's certainly an interactive way to do this, and I think we have enough clickers for everybody. We have an extra one here if you need. And this is certainly anonymous, but it's one of the advantages. Let's see, the polling's still open.
We have, we need just the one more response. No pressure.
Okay,
I
let's see.
don't know. Okay. Did we do it?
Yes. Okay, so we have some overvoting, but that's fine. It looks like people are pretty well-rounded in the sense of, fitting their preference to possibly the situation and the task. Now that I will say doesn't surprise me, because context matters. You may have a preference that changes. If you're really struggling to keep up a schedule, you may be more of a self-paced learner. You want to fit it in when you can. On the other hand, later in the year, when your schedule lightens up, you may prefer the live. You may get more out of it that way, whereas you couldn't concentrate at a live activity because all of the things you had on your mind during the busier part of your year. So I don't think these preferences are necessarily affixed to your personality. I think it can change. Now let's get to the pre-work that you all did. Did everyone have a chance to at least glance at it?
And able to score your own preference, and you hopefully find that useful. So one of the advantages of doing things like pre-reading, once again, as Rob mentioned, is the fact that it kind of offloads a lot of the instruction so you come ready to learn. So by having you do this work in advance, obviously the 6 or 7 minutes, 10 minutes it will take to do this, you actually have that completed, and then be able to think a little bit how you might be able to apply to the learning situation we have here. So here's just one example, and it's covers those 4 areas. So.
So we'll just run over them really quickly. The visual, are you someone who prefers visual? Are you someone who takes information and retains it better from hearing it, auditory? Someone who reads and writes to retain it, a note taker? Or someone who wants their hands-on and has a kinesthetic experience? Those 4 broad ways of really preferring and better retaining information. So let's pull in and have you share what your assessment determined about you. Are you mostly V, mostly A, mostly read-write, R, mostly kinesthetic, or often the assessment can give you sort of a 2-pronged dominance, multimodal, or even balanced among all 4?
So when you scored your rating sheet there, you came up with a number, and so let's see what you get.
We have 6 votes. Anyone else? Okay. Oh, well, that's interesting.
It is.
That actually is somewhat surprising to me.
It's the same here. I've not found that. But once again, one of the advantages of having a interprofessional group might work a lot with physicians. I find that it's mostly the visual and the reading and writing. But so we have others. That's good.
Yeah.
So we know learning different preferences. And so why is it important that we know something about different styles of learning when we're teaching? Pardon me?
It would help you how to teach.
Okay, how might that happen?
Well, if 50% of us are good learners with
Yeah.
hands-on, you would create a hands-on project.
Now, that would be lovely if we could.
Instead of 0%.
It'd be good if we could customize all of these. But when you have an audience of 100 and some odd folks, you can't have everybody do this, and you wouldn't customize for just that. But the idea, and I always stress this too, is again, about variety. So think about visual learners out there. What might you apply for them? Some kinesthetic activities, which we'll do in a little bit. But once again, to think about the multiple styles of learning. I think that's really kind of the major point here.
Yeah. Variety, reinforcement, something for everyone. So there are some other frameworks that, if you're interested in exploring ways of measuring personality and extrapolating from that, ways into learning and retention, the big five-factor model is one that has sort of 5 axes: your openness to new information, your creativity, your extroversion versus introversion, your agreeableness, which generally means will you go along with the task presented to you. And I don't like the term neuroticism, but it's generally more thought of as the anxiety level that you tend to have about new tasks. The other one, which probably is much more well known, is the Myers-Briggs type indicator. I know a lot of people that were in social science degrees probably went through this in their training and got their MBTI. I guess it's an acronym. Mine is ENTP. My personal test was that. That takes a little bit longer than even VARC does to complete the assessment, but it's a very interesting one, and it in a moderated context can give you some insights into your audience. For example, the extroversion versus introversion axis. Extroverts want to participate right away with questions, almost as soon as a lecture begins. Introverts want the extroverts to shut up so they can think. And so when you have a mix of those people that the extroverts really think by verbalizing, the introverts need the dead air to be able to think and make connections. So it really does provide a challenge in designing a learning format that allows space for both and doesn't favor one type of activity over the other. So, there's some very big differences along those axes. Again, you'll have links if you want to explore further. So then we come to sort of norms used in your profession. These can vary widely depending on your license and your degree. But there are four main methods that I could sort of come up with off the top of my head. The update method, which is sort of continuously additive. You review the status quo, but then you add new ingredients. There's the group case study method, where a group of people gets together and talks about a case, and maybe different professions have different perspectives on the case. Individual case study, where you're maybe working alone, self-directed. And then simulation case method, where you're really jumping in, and maybe it's a standardized patient in our sim center working with you, so that you really have that high fidelity experience. Those may vary across the preparation each of us had to get into our job. But let's talk about, from the standpoint of visual, auditory, read, write, and kinetic, which do we think the update method taps into the most? Is it more visual? Is it more auditory? Is it more read-write? Is it kinesthetic? Okay. That was what I sort of thought. Read-write could also be tapped in, depending on, how it's delivered. How about the group case study method? Visual, auditory, reading and writing, or kinesthetic? Say again?
Right?
Auditory? Now, this is just me. I said I thought it was all but possibly kinesthetic. So there are no right answers here. It's just a sense of, what parts of your learner's abilities are you tapping into with each approach. And some of these are very similar. Group case study, individual case study, maybe similar in the materials you use, but where and when different. And then, of course, I think the individual case study is much more of a read-write emphasis, maybe less effective for retention than the group case study method. If you have to do a case and you bring it in as a pre-activity in a flipped classroom setting, then you maybe want to bring it back into the class as well, so you get sort of multimodal reinforcement in class, visual, auditory, and in addition to the read-write. And then simulation, I think, really hits all four. Possibly less read-write.
Probably just BA and K.
Yeah. But a simulation might involve chart review just prior to visiting with the patient, the standardized patient. It might involve some aspects of that. It's really up to the learning planner designing it. So just some important aspects of those designs to think about. And if anyone feels like sharing kind of what were in your professional preparation, what were the norms used in your training? Did it slant more toward visual, more toward kinesthetic?
I think it was a combination. You read something, teacher teaches it, and then you practice it hands-on.
Mm-hmm. And you're an athletic trainer, yeah.
Or just mix it hands-on.
Yeah.
But, you gotta be taught it first, and read it somewhere, or see it somewhere.
Mm-hmm.
I think medical school is all reading and vision.
Yeah.
Uh-huh.
A lot of lectures.
Now it's changing, I think it's
Yeah.
more hands-on. But when I went to medical school, it was not hands-on.
Mm-hmm.
It's still seen as the most effective way of delivering educational content to a large audience.
From the aspect of time, yeah, and resources, sure. And do you feel like it's the most effective way for retention and
No.
no?
I think, we know most CMEs are lectures, and that's not the best way.
It's the easiest way for the people putting on the education. Retention and translation to practice are really important. And I think especially in those sort of preclinical training years, if you're giving people just read, write, how many times does that need to be reinforced? And is it efficient from the standpoint of their time if they're having to go over it and over it and over it? It may be more efficient from the standpoint of the educators.
My daughter was learning about China, and they did a little thing on Confucius, and they had these sayings, proverbs, basically. And one was, I hear it, I forget it, I see it, I learn it, and I do it, then I know it. Which, I mean, that's from Confucius, so clearly medicine can change a little, should change and adapt a little bit.
That's great.
Advanced organizer.
Yeah. So just real quick, again, another poll. Which do you consider to be the most effective format for prompting changes in the clinical practice of your colleagues, people in your licensed profession?
Well, that's a difficult question, because what's challenging in medicine and the physicians is that you would like to prompt changes, but there are a lot of people who are kind of in their own routine, and prompting changes will require a complete change of the way of being in some ways, or way of thinking. And in doing that, you have to really get them motivated to do it. And motivation can't, they are, well, I'm very busy, I have clinics, I have this patient, I have this teaching, I can't come to a simulation case. But that's until you actually show them and prove to them it's going to be better by changing.
That's a great insight. Right. You almost need to, the first date needs to be maybe a less of an invasive format so that you can prove the value and then get more in depth as that's a very good insight.
So what would be considered the most effective? It depends on if you have a buy-in by the learners.
Yeah. Did you vote on the poll?
Did I vote on the poll?
Go ahead and poll. We have 6 so far.
Oh, I'm sorry. I thought.
No, it's fine.
Okay.
No, it's fine.
It didn't even dawn on me that
Just to see if there's a consensus.
Oh, sorry.
I mean, I actually think your point is a very, very good one, that you can't just put it out there and have people, accept it. So 8 responses. The group. Interesting. So nobody felt that the individual case study really helps promote practice change. And update was the most well-liked, and simulation next. And group maybe least. And that there is a variety of licensed professions in this room. So that shows some sort of the differences across the landscape. The professionals maybe have different ways of translating. Does anyone want to verbalize why they voted one way or the other, or illustrate a reason?
I think I already did.
But I think with case studies, I think it's almost patient and diagnosis, and in terms of changes or updates, you're able to use that, and I think it's most effective for the physicians to learn and to try to apply that. Practice.
Yeah.
They're hard to change unless you actually have them physically do it. So, if
I
they
feel
say,
like,
oh, well, this study showed such and such, now you should change your practice.
I know.
Well,
I find that that's a little bit better than just kind of like going through like updates and guidelines. Like, oh, you should do this, A, B, C, D. If there's like kind of cases.
yeah.
Shows an outcome.
I see
Sure.
what you're saying.
Yeah.
As opposed to just Should I update ABC? Yes. Yeah.
And it makes it more salient as well, I think. So I won't go too much more into detail on this. I want to leave time for Jack's session, but learner context analysis is a process that you can do to sort of look at what's all available in your tool set, including AV, furniture, the predisposition of learners, and it's a good sort of a checklist to go through when you're picking your learning formats. We wanted to discuss barriers you've faced in acquiring learning and barriers you've faced in translating learning. But I think I'd rather give Jack the rest of the time, and maybe we can conduct this discussion by email after the class and get you to the workshop part of the...
Can I just ask one question before Jeff takes over? I'm wondering, in terms of specifically for physicians, how you can have them have a activity but kind of do competency, but not do competency. As an example, I'm trying to figure out how to do a airway course, an advanced airway course for ED attendings. So I'm not an expert in airway, teaching them airway. So I don't feel like I can critique them to say, okay, you passed this course, now you are credentialed to do any airway whatsoever. Because then someone legally could, down the road, say, oh, well, they missed my airway, but they went through your course. Do you understand what I'm saying?
Yeah, that certification and competency, competency with a big C, I think is different if it has legal aspects, like certification. But let's take this offline and maybe talk after class, because competency with a small c in Moore's is reproducing the skill, not necessarily how good are you. So we use the term competency maybe in different formats. So
one of the things that we have is showed here is the learning environment. So those of you that come to other sessions, you notice how we changed the format for the environment here. So perhaps it's a bit more interactive than it was an audience setup with the chairs all facing in one direction. So simple things like that. So we're going to get a chance for some cooperative learning here in just a little bit. For those of you that came to the session before, we did. So we started off looking at what are the needs of our learners, right? How do we measure the needs? How do we know what the needs are when we're putting together a CME application? Last time we looked at how do we write learning objectives, and that's part of the handouts too, and you remember some of this too. So we'll look a little bit about instructional design, think about higher order thinking skills, once again, how we might apply those to active learning, and look at how we might be able to do that for quality improvement. Thanks, Rob. Appreciate that. So once again, this is a refresher. So so we want to make sure that part of writing learning objectives is not so much for the benefit of the learner, but also beneficial for you, so you know what the outcome. So what do you want at the very end? So you want your learners to be able to measure something, be able to construct, be able to discuss, whatever that it is. And putting those in specific terms helps you actually measure outcomes, so you know you made a difference, and that's the whole point for it, Rob. So instructional design, my doctorate in education is on instructional design. Many courses in this, but basically it's to be able to design instruction that meets the needs of the learner. That's really kind of the punchline for it. Certainly based upon theory. Some of you, Jenny knows about, Rob, know about Class 6 criteria, which I'm not going to go into at this point, but other than the fact that it takes elements of preparation, elements of active learning, elements of outcomes, how you can measure outcomes. And last but not least is reflection. You need to reflect on your own teaching experience to say, what did I do well in this class? What can I do better next time? Because who's going to monitor you if you don't, right? Because you want to be the best teacher that you can be. So that really is some elements of doing that.
oops, sorry.
So anyway, I think I've got my short-term memory tells me we just did something in this from Confucius. So thank you, Jenny. And this wasn't planned. So what do you think people generally remember when they learn something? So
12%.
if they see something, what is that? Well, you know Confucius. And Confucius would have said that too. What percentage do you think that they only hear something? like a lecture? How much of that is retained, do you think?
22%.
22%.
I'm on a roll.
You are so good. Faculty scholars. When you put those two together, you hear something and you see something. Of course, you've already touched upon that, right? So what do you think?
It's more.
Yeah, it would be more like maybe 40, I don't know, 32. How about that? And you put all three of those together. So once again, thinking about the levels of competency, be able to know something, content in terms of knowledge, in terms of its application, and be able to see it and do it. That's why the Sim Center is one great opportunity for doing all three of these. And so once again, it's just the whole point about how this is a kind of additive in many respects, right? Okay, so the basic idea here about having themes, and one of our themes that we've had for this whole series is on adult learning, and especially meeting the needs of the learner in many ways, looking at assessments, looking at how we design instruction. So having a theme that might run through this. So for instance, sepsis could be something that you might do. You might discuss that in a journal club. You might have a case conference for residents. You might use that in a QI conference, or even have a grand rounds or a CME course. So having a theme that runs through kind of reinforcing a basic concept. So there's lots of educational theories, and some of you may know some of these. And so the whole idea about experiential, we learn from experience, right? As adults, especially. Children don't have as much experience. Well, the older we get, the more experience we have, but some of these are real advantageous. So you learn have a concrete experience, learning experience. And you be able to reflect on that experience. Gee, what did I really learn here? And then you have some abstract concepts. So how might I use that in my own world? And so the more you think about this, the cognitive aspects of that, and then you retest that and you think, well, I'm going to try this strategy for teaching, okay? Some of that individualized activity that you have. That goes back into the next concrete experience. So this whole idea about experiential learning, this is just a small version of how this might happen, but especially the abstract conceptualization that really occurs. And I think if you think about all your learning experiences, they really do this, not just in isolation. You put these together and you begin to think about how I can use this and improve.
Whoops.
So some of this, we have a worksheet here that's going to give you the last 5 minutes for here. Be able to use this as a template that I put together for when you're designing any course. Okay, it could be a single lecture. It could be a whole, it could be a CME course. Revamping the medical student curriculum could probably fall in this too on a much grander scale as we've done. But anyhow, we'll go through that in just a moment here. But basically this, so think about what say you're thinking about this now because you're going to get a chance to do this. So think about a topic that you want to teach. Okay. Something with respect to, Linda, if you don't mind, maybe like an advanced directive, just as a concept. Okay. So what are the needs of your learner? Depends on who your learners are. Okay. What is the goal that you want to achieve? And what are the learning objectives that you would have? Be able to know what an advanced directive is, be able to look at how you would actually construct one, what are some of the obstacles. I mean, you can think of things like you do. What outcomes do you expect? Educational activity. Is it going to be writing something? Is there going to be some visuals along with that? Is it going to be a case study? How are you going to know performance outcome? How do you know that you did a good job? You could have a quiz, right? Or they could have a instrument or a form that they would complete that you would evaluate. Okay, and this all becomes kind of cyclic in a way. It really helps us design courses. So it gives you just a quick overview, Rob.
And one thing I do want to point out, the evaluation performance improvement, if you're doing for example, a grand rounds every year, we encourage you to recycle the outcomes data into your needs assessment the next time. A CME course that occurs every year, that participant feedback is next year's needs assessment, or can be, doesn't have to be.
So we talked about Bloom's taxonomy before, but the whole idea is about higher order thinking skills, as I call them, the HOTS, right? So you start from basic knowledge. I mean, it's like everything when you were in college, the first 2 years of college were right here at the knowledge level, So when I took my first chemistry course, okay, I wouldn't actually have application of that. And you think about your own too. So looking at arterial blood gases, okay, that would be a higher order thinking skill in terms of how you'd be able to measure those things and apply those. But it's everything that we do in education. The higher up you go, the more difficult it is to be able to measure. But if you use simulation as an example, would definitely be application. So how well are you able to perform CPR as an example? Okay. Or given a case, what would you do differently? So the whole idea is about higher order thinking skills that meets the needs of the learner. So once again, being learner-centered, once again, is kind of redundant in terms of meeting the needs of the learner and making it more interactive. Let's see, last one. So this is a template. So what I want you to do is to be able to think on your own here of a topic. It can be anything. It could be on tying shoelaces. It could be on my favorite one is tying a Windsor knot. How you make good with a teacher. Pick anything you want here. So think of a topic that you need or a subject that you would want to teach somebody. And I give you the learning verbs that go along with it too. That's attached there. So think of a topic. You can go back to the template. So think about who your audience is.
What do you mean by instructional unit?
It could be one simple thing as this class could be. Is one unit of a whole series. And a series of what, 6 or 7.
So like for a course, so for each
So
day.
a course could be. So if you're having a course in like biology, as an example, so one unit may be on nomenclature. Next course could be on differentiation of different species or something like that. So each class could be an instructional unit unto itself. Take all of these and build these together, you got yourself a whole curriculum. So think about what we do with medical students. So they have lectures on the central nervous system. Okay, that's a part of a neurology course or neuroscience course, which consists of many other activities, which is also a part of their first year academics, which then is a part of a 4-year. So all this kind of links together. But just think of one simple activity that you might want to do. You can't pick Sorian because that's too complex. But something more simple that you might want to do. Athletic trainers first name. Dan. So yeah. So
Thanks for coming.
Yeah. So I had foot surgery, as you can tell here. So it's been
Some time?
It's been 4 weeks now. So using you as one, or using us as one example, you could imagine. So years of running have taken their toll. Hallux, abductus, worse. So we put a screw in there and everything like that. So that's just, I would
So the
definitely
educational needs.
the educational need for me to make sure that I'm ambulating properly and I'm taking, doing all the little exercises that I need to, and what objectives might I have for that. So I would, as a patient, I would need to know what the limitations are, how I might be able to identify those, what kind of restrictions I might do. Some mental health therapy too, because I can't do anything. And what the outcomes might be. So, I mean, from an educational concept, you can put that in that kind of a framework too. Or you could just use the anatomy part. So I see the X-rays. So how would I interpret those? I use those for designing a patient care plan, as an example. So think about, once again, measurable learning objectives have a lot to do with evaluation and outcome. Learning activities could be a variety of things. It could be writing, like you're doing now. It could be sharing together. It could be a video you could go along with. Think about all the things that we've talked about. It could be, think about using a flipped classroom model. maybe see a video beforehand, discuss it in class, do a reading before class, share it in class together. A whole variety of learning activities that you might do to help do that.
And one thing, because we are a little short for time, I want to offer you all a consult opportunity. What I think we'll do is we'll put each of these 6 free text answers into our post-course survey, and if you want to treat that as a rough draft of a course planning application, and let us know, I want to consult. Before this class meets again July 13th, I'd be happy to follow up with any of you and help you trace through some of this. It's a lot to try to put down on paper right now in only a few minutes, but if you are working on a draft course that you want to prepare, I'd be happy to do that with you and over the next few days.
Coming up, or a topic or an instructional activity that they're doing with anybody on any topic coming up in the near future? This could be a way, do you want to bring it and help you refine it so that you feel that you're successful. That's what you want to do. You want to meet the needs of the learner, and this really focuses specifically on that. And so think about the outcomes that you might have to know that you really got your goals across, you got your objectives across to the learner for their satisfaction, but then for you too as an instructor, because you want to do the best that you can.
Anyone have any questions to clarify what goes into each of these boxes, or? Okay, so I'll send out a few minutes after we break up, I'll send out that survey with a link, and you'll also have the opportunity to do your credit certificate to get your CME or CE for today. And then just a commercial for, not only does Jack have 2 great modules on our InReach system on designing that'll really elaborate on today, but we also have the rest of this series, taking a break for the 4th of July, but test item writing, Jack will present that on July 13th. And then Mary Cataletto will do some of the interprofessional stuff. We'll go over some of the delivery and resourcing at the 6th meeting, and then outcomes, which was sort of my bailiwick before I came to Winthrop. We'll go over that at the end of the series. So please continue to join us, and thanks for coming today. Any last questions?
What did you find most useful today?
I like that questionnaire. I thought it was pretty revealing.
The self-assessment?
Yeah.
Yeah.
Good. Think about applying that to instruction. Anybody else? What did you find particularly useful that you're going to put into practice?
Is instructional design?
Yeah, I think so. I appreciate that. That's really kind of what the focus is. Those in 2 weeks, writing effective multiple choice questions, especially board type questions. They don't have to be necessarily, but that's what we wind up doing. Multiple choice questions are probably the easiest thing, so we can test knowledge, right?
I can see where this would be a bit of a daunting task in the beginning, but in going through those steps, forcing yourself going through those steps, you basically have your course set.
There you go. Thanks very much.
Absolutely. Well, thank you all, and feel free to email any questions, but I will definitely react with feedback to what you put into that survey. So enjoy your 4th of July holiday. Do you want to have a sidebar?
Yeah, certainly.
So, yeah, the competence and the certification piece, those
We'll
are,
be talking to you more about this that I'm trying to form, put together, because there's some, so basically, Joe Greco and Mary said to me, what to do in every course we're attending is, because you're supposed to have 5 airways for 2 years in order to keep your credentialing. So, a lot of individuals have it. There are some that don't have the 5. Basically, it's like a checkup. Like you check it off, you put your initials in.
I was here in the first one. Yeah. Yeah.
So there's
last
more
one.
like quality control in terms of how well you do it.
particular topic.
So is the curriculum already formed from some, there's no first aid,
So there's no-
Red
there's
Cross or
no-
any of those curricula?
There's no
Okay.
like standard. That's what the challenging part for medicine. Another challenging part is that it's not standard for hospitals. You know, like I just happened to glance at thing somewhere in Duke. For their credentialing for sexual knowledge, you have to do 10 in 2 years and prove that they're successful. Like, what does that mean? They're all very vague. Partly by design, partly by pressure from like older attorneys that want to go through CME stuff and
Yeah.
take their time out of their life to make sure they know how to do the procedure. And finally, for people who have done it so often that they're like, I'm gonna do it.
Yeah.
So, but the thing is, I don't feel comfortable like signing off saying, okay, this attending went through this course, they did all these 5, scenarios that I have for them. Then they should be able to be credentialed. You understand what I'm saying?
Yeah, so.
So they're competent in doing
Was
this.
Greco and Rosenthal's motivation to require it, was that coming from some sort of regulatory body or agency?
I think they're just getting a little more stringent on within window. I don't think it's
Okay.
from higher up, which I agree with. I think there should be some sort of standards for
Yeah.
certain procedures that we keep up our skills.
Well, I think it's
But-
worth pinning them down to have a discussion exactly what they think should compose the criteria, the standard.
Well, he basically said, I trust you, you can go ahead and do whatever you want, sort of thing.
Okay, so there's the one approach would be to go very academic, do literature searches, find best practices and specialty board guidelines. Another way would be to convene a group that would sort of steer it so that sort of distributes some of the responsibility. It can be terrifying to venture into something like this that has those implications. If you can be in a steering committee, maybe get oral maxillofacial dental, because they have to be certified in their way, I believe.
Okay, you
Emergency,
here now. I look forward to it.
you know,
Next time.
some of the life-saving BLS experts. Get multiple professional perspectives and see if you can come to a consensus of what the minimum guideline would be. And then before you deliver that, present that to Rosenthal and Greco and say, this is where we're heading. But, remove any sort of element of working behind the scenes and taking on the risk yourself, because I do think it's fraught with blind spots. One person can only know so much. But if you convene a consensus committee, I think that's the best way to achieve an institutional standard, rather than, this is just one doctor's opinion of how it should be done. Other people will then have ownership. The academic way, I'm sure there are guidelines, but that's a more time-consuming process and more research-driven. It's great. It's evidence-based. Maybe we'll lead you.
But the challenge is, yes, and I agree what you're saying, and that would definitely diffuse some of that. The challenge is that everybody comes with a certain level of ability. Like all the attendings that I'll be having coming through, I would say 60% of them do airways on a regular basis. So they have their routine, right? There's some that do it occasionally, some totally shy away from it. And then there's certain airways that none of us do very frequently. And that's more of a review of how to do it. Like the crikes, where you can't get anything in, you have to surgically open up the tube and surgically open up the larynx and put a tube in. So, I've probably done 3 in my life. But it's something that we are supposed to be able to do.
So I think there's a survey component of it. So airway is not just one thing.
I've talked to a lot of all the attendings, they want crikes, they want glidoscope, which is like a newer technique using like a video camera in order to do intubations. More of the advanced,
Right.
not the plain old, and like an angioedema where the tongue is swollen, like, talking about that. So, so I have an idea of what they want. It's just a matter of, does that then mean they're going to say, well, they went through the SIM course, so they should be credentialed, so if something bad happens, legally then I'm bound to, I signed off on that quote unquote, having gone through this course.
No, CME isn't signing off on.
They are competent in their,
And generally, insurance doesn't take CME as any sort of evidence of competence.
okay,
Maintenance of certification, yes, and we're just getting involved in that here at Winthrop. It's complex. I think you don't have to worry about just providing a CME course as long as it's documented based on an evidence guideline basis. Then you're protected by that. You're not
okay,
saying,
got it.
this guy did an hour in the sim lab, send him in to save the
Right.
baby, That's, the other thing too is professionals have responsibility for their own actions, so it's not something that they can just
off.
inherit from a certificate. So, I would,
So that
I would
seems to be
definitely,
less of an issue if I'm just making a CME type of.
yeah, I would definitely look at convening an expert consensus committee to sign off, a planning committee. We do that in any CME, there's a planning committee. But rather than just having sort of mid-levels and attendings, maybe get various professions
Oh,
involved.
Matt Juka, who's anesthesiology, he's working with me as well.
Yeah,
So
yeah.
those are the two main ones.
And are you concerned about how you will measure, or you can do it. You could do a post-test. You can do an OSCE-like assessment in the sim lab.
Yeah, that's probably what I'll be doing. Having them practice the airways, having them practice the glidoscope, having them practice the crikes, and then the last time would be like a scenario where they would have to manage the whole case, like a conscious sedation that goes badly and will require a difficult airway. That's
Yeah,
something.
well, and that's a pretty well accepted thing. My old medical director used to say it all the time. See one, do one, teach one.
Right.
So if they're escalating up the chain of command to that final case where they're running the case but also problem spotting
Right.
for others.
That's my goal for the 5 different scenarios. But
Yeah.
the challenge there is also getting 20 attendings to come for potentially 4-hour course. That's always.
Well, what if you
it's
broke it
always
up? Make it a series. Make
But
it
that's-
discrete
I
procedures.
know emergency medicine doctors are like, I'd rather just like bang it out all at one time
Mhm.
than coming multiple times.
And
So-
that's a good lesson in our course today. What's the norm?
Yes.
Yeah.
I mean, it really depends on the specialty. And people are like, let's just do it, get it done with. I'm not
Mhm.
going to come back another day.
And do you feel that the
It's a
scale of 20 people would change the level of?
Oh, I couldn't do 20 at a time.
Okay.
I would have to do maybe 4 separate times. But it's going to be mandated by Barry Rosendahl, so
Yeah.
it's like,
Oh, that's the incentive.
yeah, your boss is telling you have to do it, so that's how it's going to get done.
Yeah.
But those are just different barriers that I'm finding out.
The scheduling part.
Yeah. So we did central lines for attendings, and we have about 20 attendings, and we got 15 out of 20,
That's great.
which is
Say.
actually very good.
In three occurrences, or how many?
It was 4.
4. Yeah, it's good.
Yeah.
That's really good.
So, there, and that's where I didn't push it too much on the central line, but that's kind of where I got the buy-in when now they got to the STEM Center, see what we have to have there, see the capability, and in talking with them, they're like, oh, we should do an airway course, and we really should practice the crike. And I was like, yeah, I'll set it up. But, so then Greco said he wants us to do it, so
Just completely
separately, yeah.
Yeah.
So, so now that's
Well, it's
where-
good. I mean, you have 2 departments backing you. So I
Oh,
think
yeah,
that's,
and the medical director is directing me. So it's gonna get done, it's just a matter of how, I wanna do it well. So I wanna make it effective, I wanna get them to get out of it, but do it in the most, I don't know what the word is, most,
Applications.
yeah, efficacious, not truncated, that's not the word, but like, as
Focused.
focused as well
Yeah.
as, like, they don't need to come in and have, lots of
Lectures.
lecture on it. They need
Right.
to come in, practice it,
but I would maybe consider interviewing Rosenthal and Greco each separately for just 10, 15 minutes and say, so following on this idea, what do you think are, the most needed aspects of this? Because that's the needs assessment stage in planning. If they had a real strong gut that this needs to be done, maybe they've seen cases where something went wrong, or they can give you some of the evidence
I
that you
did
can
try to
then
have, I
cover.
had that conversation, they both were very vague about it. And I know one of the reasons is Dr. Greco wants people just to practice because he has to sign his name on our application every 2 years, our application for
Yeah.
doing the privileges.
Are there quality measures that say all level 1 trauma centers are judged by specifically in the area of airway? That, like, can you tap into those scores to get
I don't
a
know.
baseline read?
I don't know, I have to look into that.
Yeah, I would look for quality data, because that'll give you, if the institution's already measuring outcomes, get a baseline before you start the course, and then you have something to look at after the course to see if the needle moved. That'll clue you into kind of
Quality measures.
what's measurable.
Specifically in that way.
I always think
Yeah.
about the flipped classroom model too, to some extent, so
Yeah.
something that they can do before they come, so they could do maybe some self-assessment beforehand to know their level of competence or proficiency or lack thereof, and so that they come with sort of an agenda. These are the things that I know I need to improve on. I mean, I don't know, they're all going to be probably different, that's part of the problem, but still you might find some consensus amongst the deficiencies.
Yeah, especially if there are some people who avoid some procedures, you can somehow get them to commit to that. Like my level of comfort with each item on this list.
So they could prioritize the list.
Yeah, and then you'll have, if you have to group them or focus on
That would help.
who gets the most time in each station or whatever.
You could say, well, based upon, the 80% of you said that the number one priority was this one. Well, that's what you wanted to teach them.
Yeah, so that would be like almost a menu if
Well,
you're.
that would be nice if I have that set up for the department meeting next week, but.
Well, it can be iterative. People can see a first draft and you can revisit it and refine.
The quality measures would be kind of helpful to see.
Yeah, talk to Monica Santoro. I'm sure Dr. Greco also knows, especially if there are things that are anesthesia practice specific.
So is there a problem with airway management? How do we know there's a problem?
No, I don't think there's a problem. Well,
I mean, are people not being intubated enough?
no, I think it's the challenge is that patients in the emergency department, for the most part, the attendings do the airway. We call the anesthesia down only when it's a really bad, difficult airway, and so there's a love-hate relationship between ED attendings and anesthesia, and that's always, it's not just here, it's everywhere. But I think just the fact that he wants to make sure that ED attendings keep practicing, and you have to have 5 airways in 2 years. So if you are an attending that shies away from that procedure, how can he then renew your privilege for that when you haven't had any practice at all? And it seems like at least having some practice in the sim center would make him feel a little more comfortable agreeing that this person is still competent to do that procedure.
And they don't have to be, and they don't have to do consults.
Mm.
Well, with anesthesia department. Right?
No, we're not involved in that. They only come down to the ER when there's a bad.
That's what I'm saying. So the more self-directed they are, they will do the procedures properly.
Yeah.
That cuts down the number of.
You're saying, right, so we don't have to call anesthesia down
needless,
for,
needless
right.
consult. So part of the question might be, how do they make decisions about getting the anesthesia consult, so that they're a bit more, so that they just don't automatically punt to the consult and says, well, this looks bad, I'm going to have them do it,
Right.
as opposed to them doing it themselves. Maybe it's too much risk and there's too much time, and so it becomes a burden then for the anesthesiology. I would think so.
I can talk to Matt Duke about that, because we have had conversations about that.
Yeah. So
When to call them early, or when to.
When do you consult? I mean, basically.
Yeah, it's just, like, if this was a, medical student or even resident, resident thing, they have so much out there on how to teach that, but not a whole lot on attendings who already have done it for many years. Like, and how do you get that engagement of people who have done it so many years, but don't necessarily do it often? You know what I'm saying?
So remember we said see one, do one, teach one. What if you could bring in the lower level learner, like the medical student, for some part of it and let them participate in teaching them to really show mastery? That adds complexity to the course, but it's another opportunity.
I don't know about the hierarchy there. I don't know if 30-year physician attendings would want to listen to a student.
No.
You would.
The other way around.
You would teach the students how to do it.
The problem spotting piece, like, okay, you're doing it, but
Yeah.
you can do it better. So it's like mini perception almost, preceptoring. Yeah, no, I wouldn't have medical students. That would.
Or even the pulmonary fellows who need to do airways. I wonder if I can work with them and have them come
Yeah.
as well. All right, that's another thought. And it's also like, they want to, they want to go in and go out. It's like, they know they have to do it, but.
What's the minimum that I can get away with? Right. Well, that's good.
Yeah, that's a really tough mindset to take on.
But you have to, that's where the buy-in comes in. So I want to get enough that it's valuable, but not too much that they'll be like, oh my gosh, this is such a pain in my butt.
So they're not going to get a certificate. They'll get a completion.
I mean, I'm going to try to do the CME stuff, but so in terms of CME, what would I have to, I should research the
I would try to get
quality measurements and.
Yeah, but that and I would try to get some sense of what the need actually is that Rosenthal and Greco are kind of not articulating right now. They're just telling you to do it.
I think I've tried this a couple times, and it's been so vague that I'm thinking of kind of getting it all together and being like, do you like this, or this? Like, give them a choice of 3 different, like one that's a little bit less involved, one's a little bit more involved. Give them a choice as opposed to being like, what do you want? Because it seems like they don't know what they want, to tell you the truth. They know they want it, but they don't really know what that will entail beyond that. So
that's sort of typical of many leaders in Winthrop. They need to have choices curated for them, and then they'll be activated.
Right.
And be like, oh, I know this
that's
is
the one I want. Yes.
Yeah.
It's kind of like me in paint colors. I have no idea. If you show me paint colors, I can say yes. If you say, well, what color do you want? I have no idea.
Yeah.
So
that's.
All right.
So that's to say, you give them maybe 3 or 4 approaches, hopefully come to some consensus about which one that they think would be the most useful. And that's kind of anecdotal in a sense in terms of needs assessment. I mean, you can look at the literature too, but I don't know if the literature is going to really show in terms of needs assessment. Right? I mean, how much needs assessment do you need?
I think if we would if I look at the quality measures and try to get some sort of backing from that, I think they would have no problem with you know, are being like, well, this is what we found in quality. I think we should do this because of that.
Yeah,
If I say that, they're going to be like, oh,
the
yeah.
5 airways a year is enough to be a needs assessment on its own. But if there's more to it that they're just not able to verbalize,
Right.
that would be good to document
Yes.
as well. Because it's part of your
But
blueprint.
Monica Santora would know that stuff. Like she knows every
She would know
aspect of
anything that the
quality. On
if
the
there's
hospital.
any external party measuring Winthrop with consequences in the area of airway, she will know. If our CMS reimbursement rate is impacted by some quality measure that has to do with airway, she'll know. There may not be one,
Right.
but she sort of deals with all of the measuring and all the rulers that external bodies put on Winthrop.
Okay. All right.
And I think of some outcome measure, how you're going to be able to measure some level of confidence.
And it's also, yes, but it's also a tricky road. Is that's my challenge is like, how can I say that you're competent when you've been attending 10 years more than I have and had umpteen number more airways than I have? Like,
Again, competence with a little c versus big C. Little c competence is, can you reproduce what was taught? Now, competence in the workplace based on risk and licensure and insurance, that's not the same way of thinking of
well, I
competence.
can't think that way.
I don't,
Think of competence as, if nothing else, just maybe as improvement.
yeah.
So if you have, you have a knowledge pre-test, and at the end of intervention, they take a post-test and there's a boost in score. If there's some way that they could self-report that they feel more confident doing airways as a consequence of this, that's sort of an outcome. I mean,
Yeah, there's also a somewhat well-known format. It's very labor-intensive, but it's called PI CME, and it involves taking a group of clinicians, presenting them with some sort of comparator data, like national level data on performance, then showing them their own level of performance to measure, and by having them either do a chart pull, pull patient charts and study and see. But so it's longitudinal. It's complex, but it's a way of getting them to self-assess their own competency, so that you're not in the competency hot seat. I mean, there's also, what if you were?
That's a great way of doing it,
Yeah,
but
it's labor intensive.
labor
for
intensive, and
everyone.
then you're also kind of opening up a Pandora's box in a way.
passing judgment.
So it's difficult to mandate PI CME because it is labor intensive. They have to really want to participate because it can be weeks of duration. What about if you brought
If I
the
would
medical?
What if I would have Barry? I mean, he can capture the numbers of airways. He could even capture who does what. Getting that information before the course, would that help kind of guide the focus of the?
There's something documented.
Yeah, if it's anonymized, then you can show them a bell curve that, X number of you have only done 3 in the last year. This other Y number of you have done 12 in the last year. Show them that, and then they'll know where they are. The rest of the room doesn't have to know,
Right.
but that can be motivational.
Because that will be a motivating factor on people to be like, okay, I should practice my airway because I haven't done any this year or the last 2 years. Okay, so get some data on airway. Barry. This is so interesting.
And there's I don't want to belabor this, but there's a way to maybe make it fun, such as like if you are going to bring in the medical students, and then the medical students teams can compete and be scored by the attendings who are each of their coaches. And then, you know, then a team maybe has the highest score, and that reflects well on that attending who coached them. I mean, that's like Sim Wars, but you know, it takes the I'm just here to get signed off out of it, and makes it, you know, more fun because they're paying it forward to the next generation.
I gotta stop talking to you.
I'm sorry.
You're just making more work for me.
I know.
Than you're doing.
You know, there's educational scholarship